Hi, everyone. Welcome to this collaborative event between the Connecticut Psychological Association Social Justice Speaker Series and the Neuropsychological Division. This marks a momentous occasion as it is our first joint event, and I wish to extend my gratitude to Dr. Tim Belluba, Chair of the Neuropsych Division, and his team for their teamwork in making this event possible. We are thrilled to have Dr. Linda Ruiz as tonight's esteemed speaker. A warm welcome. I am Shiva, the chair of the Social Justice Committee. Our passionate social justice and the neuropsych team members join me today. I warmly welcome our two new Social Justice Committee members, Kyler and Sydney. Neda, unfortunately, will not be on the committee, but we wish to convey our appreciation for her valuable contributions to the Social Justice Committee. And as always, I would like to express sincere appreciation to our 2023 sponsors. Their support is the cornerstone of our ability to sustain this series. So as you see right now on the slides, we have our donors in the platinum, bronze supporters, and friends level. As you see in the platinum level, we have comprehensive neuropsychological services who donated us for the third consecutive year. Thank you so much. And also you see your beautiful names on the slide. We also have good news about a new donation. And now I'm going to turn it over to Anne to share the exciting news about the recent support we received.
Hello, I'm delighted to share that the CPA Educational Foundation, which largely underwrites this series, has granted us $3,000 to support the Social Justice Speaker Series. We are thankful for this generous support as it will enable us to forge ahead with our program planning with great enthusiasm. On behalf of the Planning Committee, we are thrilled that you could all join us this evening, and we hope that you continue to attend future speaker series. We are excited about the presentation from Dr. Ruiz. And as a quick reminder, the CPA Social Justice Series offers free monthly meetings to CPA members, the broader Connecticut community, and nationwide supporters. I welcome you to our speaker series this evening. Now I will turn it over to Dr. Tim Belluba to share our speaker's biography with you.
Hi, as a representative of CPA Neuropsychology Division, I'd like to thank the Social Justice Series Committee for welcoming us and for providing this opportunity to talk about issues related to social determinants of health and disparities in health outcomes as social justice issues. It's my pleasure to introduce our speaker, Dr. Linda Ruiz. Dr. Ruiz is an assistant professor of clinical neurology at Yale School of Medicine in the Neuropsychology Division. She is a neuropsychologist, bilingual in English and Spanish, and she provides outpatient neuropsychological evaluation services in the New London office of Yale Neurology. Dr. Ruiz earned her bachelor degree at Stanford University and her doctoral degree in clinical psychology at DePaul University. She completed her postdoctoral fellowship in neuropsychology at the VA Maryland Healthcare System, where her training and clinical expertise encompassed evaluation and treatment services in both the inpatient and the outpatient settings. She also collaborated with multidisciplinary teams to meet the complex needs of patients treated within the VA Multiple Sclerosis Center of Excellence and the Epilepsy Center of Excellence from a whole health perspective. In addition to her clinical work, she has published research on the role of neighborhood context and school climate in academic achievement, as well as the relationships between neighborhood socioeconomic resources and crime-related psychosocial hazards, stroke risk, and cognition in older adults. Thank you, Dr. Ruiz, for coming to talk with us tonight.
Thank you so much for that warm welcome. Everyone can hear me okay? Excellent. All right, let me share my screen one moment. All right, is that visible to everybody? Great. So I'm Linda Ruiz, and tonight I'll be, talking about the environment, so poverty and the environment as social determinants of cognitive health. So just to give us a sense of where we're going today, first we'll be talking a bit about social determinants of health, just defining what they are. Then we'll talk about the environment of poverty and how it can shape an individual's life experience and contribute to health inequities. Then we'll look at some research that highlights just how much neighborhoods matter for health, particularly for our aging populace at the national and state level. And then finally, we'll end by talking about some initiatives and interventions to address health inequities that take into account social determinants of health with the goal of reducing health inequity. All right, so first let's talk social determinants of health. What are they? So according to the World Health Organization, social determinants of health are the conditions in which people are born, work, live, and age, and the wider set of forces and systems that shape the conditions of daily life. So the WHO made a formal declaration on social determinants of health that basically the guiding principle is that health and one's ability to achieve optimal health is a fundamental human right, regardless of race, political belief, and socioeconomic status, and that social determinants of health can be a major barrier. There's a growing recognition of the importance of social determinants of health as a matter of health equity and social justice at the national level as well. So here we see the CDC's program, so Healthy People 2030 is their initiative towards setting national objectives to promote public health over the course of the next decade. And social determinants of health is one of the major priority areas. So why do they matter? Again, social determinants of health, which are non-medical conditions that can influence health outcomes, are significant, very significant. So in research gathered by Hacker et al. As part of the CDC's task force on addressing social determinants of health, it was estimated that conditions of life, including socioeconomic factors and structural racism, can drive as much as 50% of adverse health outcomes. So as we see here in our little diagram, the problem is big, it's complex. There are also many ways of approaching the issue at several different levels, which we'll get into a little bit later. But going back to our diagram here of social determinants of health, it is clearly a multifaceted construct, and all of these facets are interconnected. And I would also add the dimensions of time and space. So I am particularly interested in the spatial aspect. So thinking about how the dynamics of a neighborhood environment can influence health. And as we dig deeper there, we'll see that there are many factors that can shape an environment and by extension, an individual's experience in that environment. But access to resources, particularly financial resources, is a major factor. So let's take a moment to talk about the environment of poverty. So just to define the term here, the poverty threshold or poverty line is the minimum level of resources that are adequate to meet basic needs. So there's a lot of room for interpretation there, but basically it's a matter of, do you have the resources to cover your expenses? And we know that a lot of people do not. It's estimated that 1 in 10 people in the United States lives in poverty or below the poverty threshold. And I also want to point out that it is actually very expensive to be poor, especially when there are financial, legal, and social penalties to not having enough money to pay bills. Looking at our graphic here, ideally, social welfare programs like the ones listed help to alleviate that burden. But in practice, we know that there are often many barriers to getting connected to those programs. And also, often there are not sufficient resources to help all those in need. So thinking about resources, the 2021 federal poverty guidelines specify that the poverty threshold for a single person is $12,000 to $13,000 per year. So that's the annual income. For a 3-person household, that would be just under $22,000 a year. To put that in perspective, for $12,000 to $13,000 a year, the hourly wage would be less than $7. For a living wage of $15 an hour, that would equate to just over $30,000 a year for income, which even that it's just so difficult to imagine living on that income. And this is also taking into account social services, so that's subtracted. It's estimated that 37 million people in 2020 were living below the poverty line in the US. So what is the significance of living in an impoverished community? So it's not just a matter of having very little money, but also poverty and the environment of poverty largely determines the conditions of life that you're exposed to on a daily basis. So we know that poverty is more prevalent among racial and ethnic minority groups, people living in rural areas, and also people with disabilities. And that can be due to a myriad of factors that in many cases can go beyond a person's individual power to control. But it impacts so many aspects of daily life, including access to healthy food, employment opportunities, education opportunities, and even education quality, housing stability, and rates of crime, particularly violent crime. So it is not difficult to imagine how socioeconomic inequities can contribute to adverse health outcomes that are amplified across the life course. So let's talk a little bit about connecting social determinants of health to cognition and aging. So just to define our terms here, I'll be referring to Alzheimer's disease and related dementias, or ADRD, and that refers to the most common forms of neurodegenerative illnesses that cause dementia. So Alzheimer's disease is the most common, accounting for 60 to 80% of cases. And this little schematic on the slide there very simplistically explains what a neurodegenerative condition is, but in essence, through a combination of factors like age, genetics, and environmental factors, there's a development and proliferation of protein abnormalities in the brain that can trigger an inflammatory response and thereby damage otherwise healthy neurons. And these tend to be progressive conditions that worsen over time. So our population is aging. We know that, so baby boomers specifically, those folks who were born between 1946 and 1964 are aging as a cohort. And the 65 plus population grew by over a third over the past decade. So there is significantly more older folks and a need for resources to address issues like Alzheimer's disease and related dementias. So the rate of individuals diagnosed with ADRDs is also growing. It's estimated that in 2020, so in 2020, the number of individuals with Alzheimer's disease and related dementias was about 5.8 million, and that number is projected to triple by 2060. And the prevalence of ADRD varies by race and ethnic subgroup, but we know from data that African American and Hispanic Latinx communities in particular carry a disproportionately high disease burden. So this graphic here shows some research that breaks down estimated prevalence by age and racial ethnic backgrounds. And again, we see that of all of the subgroups, African American and Hispanic Latinx populations have the highest prevalence of ADRD at every single age interval. And that disparity is likely to continue to grow. So by 2060, minority folks are projected to represent 45% of people aged 65 and over, which is an increase of 22% from 2014. So the next question is, what might be driving that disparity? So in terms of socioeconomic factors, we know that, well, socioeconomic status is a construct, but it basically indicates degree of privilege. It typically encompasses factors like education, income, and occupation, and access to resources. So this data here shows that individuals who live in counties with the lowest rates of Alzheimer's disease and related dementias also tend to have higher levels of education, lower levels of poverty, and more access to exercise opportunities. And that's true across all groups. And here we have a visual representation of data from that same report that highlights the top 25 counties with the highest prevalence of ADRDs for each subgroup. So just kind of looking at these spatial patterns and letting all of that sink in, it brings up a lot of questions for me. So, you know, what is unique about the places where prevalence of ADRD is higher? What do we make of some of these clusters where specific subgroups seem to be particularly vulnerable? And what are the social, economic, and political factors that might contribute to some of those inequities? So I think one step towards making progress and promoting health equity is quantifying these disparities so that we can better define the problem and work towards solutions. However, it can be really difficult to quantify the extent to which an environment or a neighborhood impacts the health and well-being of communities or individual people. Luckily, there's a lot of talented people working on this issue, and a lot of progress has been made to compellingly demonstrate that neighborhoods do significantly impact health and even life expectancy, very specifically by zip code. So let's take a look. So the Center for Health Disparities research team at the University of Wisconsin has done amazing work to quantify and also make available data on neighborhood disadvantage. So they've developed the Neighborhood Atlas Project, which is a data sharing platform that helps you quantify, map, and visualize relative differences in socioeconomic disadvantage, both nationally and in specific states. So the crux of this project is the area deprivation index that you see on the left there. That basically it quantifies this theoretical domain of area deprivation by taking into account things like income, education, employment, and housing quality. And the intention really is to inform health delivery and policy, especially for disadvantaged neighborhood groups. So looking at this mapped out for the United States, you start to see some patterns in terms of where folks or where communities are most disadvantaged versus least disadvantaged. And we also have that same data for Connecticut. So we start to see that there's kind of clusters of more disadvantaged groups around major cities. We also have here life expectancy for folks in the United States. So the areas in red are areas with lower life expectancy, and areas in darker blue have higher or older life expectancy. And again, the same for Connecticut. So doing a little side-by-side comparison here, this is area deprivation index by life expectancy in the US. And you can start to see some spatial correlations. Really, the next step is aggregating all of this data and doing some spatial overlays and statistical analysis to see to what extent this is actually significant. These spatial relationships are significant. And I'm working on getting my mapping skills there. Not quite there yet. Here we have the same two graphics for Connecticut. And again, on visual inspection, there are some trends here. You see there are some areas where you kind of see it going in the expected direction. So where areas with higher neighborhood disadvantage tend to have lower life expectancy. However, there are some areas that do not follow that trend. So looking specifically at this area right around Torrington, there seems to be some significant discrepancy there. And then also out here in Eastern Connecticut, there seem to be some major discrepancies there. So interesting to highlight those discrepancies. And then I think the next question is, well, what accounts for that? How is it that, you know, these areas might have higher levels of neighborhood disadvantage, but the life expectancy statistics are not as poor as would be expected? So some additional information, depressing information on life expectancy at a national level here, there can be significant gaps in life expectancy depending on where you live. It can vary wildly, even within one city, literally based on one zip code. So this shows the cities in the US with the highest life expectancy gaps between areas with the lowest life expectancy zip code within a city and highest life expectancy. And you can see that the discrepancy can be a matter of decades. So for example, in Chicago, depending on where you live, you might on average live 30 years less than someone who lives in an area with the highest life expectancy. They also calculated the areas with the smallest life expectancy gaps. And that can be as little as 5 or 6 years. So it's interesting to see the difference between these areas. So these seem to be major cosmopolitan cities. The areas with the smaller life expectancy gaps, a lot of them are in California, but they also seem to be smaller cities. And potentially, I would guess that they're areas with higher socioeconomic resources. So in summary, social determinants of health can significantly contribute to health inequities. Poverty significantly contributes to neighborhood disadvantage, which shapes the conditions of life to which one is exposed on a daily basis. And there is a correlation between location, health, and aging that can significantly influence one's lifespan, in some cases by a factor of decades. So what do I do now? What can we do to healthy aging? Oh, can everyone still hear me okay?
Yes.
Okay, good. So just zooming out for a moment, hopefully we've established that neighborhoods matter for health and aging. And we're aware that there are a myriad of mechanisms by which a neighborhood environment might lead to health inequities. So this schematic here is, this is taken by a seminal paper in 2010 by Drs. Diaz-Rue and Meyer, exploring potential mechanisms by which neighborhoods might impact health. So looking here at the leftmost side, it takes into account social, economic, and systemic factors that can influence the non-random distribution of people and resources. In the middle here, aspects of the neighborhood's physical and social environments, the extent to which those factors can cause physical and psychological stress to shape behaviors, the personal characteristics of individual people, so things like material resources, biopsychosocial factors, and biological attributes or genetics, and how that moderates all of the above. And then finally, how all of those things come together to impact health. So in summary, neighborhoods are a key social determinant of health, a key context for social determinants of health. And capturing and quantifying the impact of neighborhoods on a group or a person is very complex. But given the complexity, there are very many ways to intervene. So again, here from Dr. Diaz-Ruiz, there's a schematic for considering different interventions and policies at various levels to address social determinants of health. So interventions can range here most proximal to an individual, targeting health behavior change, working with either individuals or certain groups at the community level. And that can range all the way to the most distal goal, which is to ensure anti-racism in all policies in the entire country, which is wonderful. I hope for that too. And it will probably take some time. In the meantime, there are other contexts and ways of intervening to promote health equity. So at an individual level, it's important to think about what are the modifiable factors for Alzheimer's disease and related dementias. So this image here is taken from a 2020 Lancet Commission report on dementia prevention, intervention, and care. And it highlights modifiable factors across the life course, which taken together can actually account for a 40% reduction in dementia prevalence if eliminated. So specifically in early life education, having good quality education and sustaining education for as long as possible, that builds what we call cognitive reserve. So it's kind of this concept of you just have more in the tank. There's more to lose before you reach the threshold where cognitive difficulties start to actually have an impact on day-to-day functioning. So the more education, the better. In terms of midlife, there are several aspects that can significantly modify risk for dementia, including hearing loss. So correcting hearing loss is actually can actually significantly reduce your risk for developing dementia. Thinking about, if you're not hearing things correctly, you're not going to remember things correctly. And it also interferes with your ability to really stay engaged with the people and things that are most meaningful to you. Try to avoid traumatic brain injury if you can. And then also there's lots of lifestyle changes. So reductions in alcohol use, maintaining a healthy weight, smoking, addressing mental health issues like depression and other serious mental health illnesses. And so again, taken together, this can have a significant impact on risk for developing Alzheimer's disease and related dementias. However, not all of these are necessarily things that can be changed by an individual, and it doesn't necessarily account for systemic factors that impact access to resources. So for example, to what extent do folks actually have control over the quality of their education, especially in early life? Do you have control over your exposure to air pollution if you live in a neighborhood that just has higher concentrations of air pollution? Can you control your access to safe green space, the availability of medical care, or even the affordability of housing? So it's notable that 60% of the risk for developing Alzheimer's disease and related dementias is still unaccounted for, related to unknown variables. I would hazard that a good chunk of that is related to social determinants of health. So coming back to the CDC's initiative here, as previously described, they have this Healthy People 2030 initiative intended to address social determinants of health. And so they have sort of this 6-pillar approach that all interact with one another. And social determinants of health is just one factor that contributes to overall equity, but is significantly impacted by social conditions and structural conditions. So what we can do to start to promote better health equity is to focus on making changes to policy and law, collecting data, and evaluating programs. So demonstrate need, partnering and creating collaborative relationships with communities. I will say that we want to make sure that we're engaging with the disadvantaged communities in ways that are not exploitative, and also building infrastructure and capacity. So this is just one example of the CDC's progress towards some objectives related to the goal of creating neighborhoods to promote health and safety. So they're essentially have broken down every goal into several different categories of objectives, and they publish how far or how much progress has been made on each of these target objectives. So in terms of targets met for the goal of creating neighborhoods and environments that promote health and safety, they've increased the proportion of people whose water meets Safe Drinking Water Act regulations. They've reduced the amount of toxic pollutants released into the environment, and there are improvements in terms of reducing health and environmental risk from hazardous sites. However, there are still other areas that have little change or even getting worse. So access to internet, that's increasingly becoming more of a basic need for folks to be able to maintain employment and social connection, to manage money, and also some areas where there are little change, reducing the number of days people are exposed to unhealthy air, reducing the proportion of families that spend more than 30% of income on housing, still room for improvement. So they have this, they have all of their goals listed out and all of the objectives, and they also have examples about how some of these goals and objectives have been operationalized at the specific community level. So sometimes it's difficult to think about, well, how do you take this and translate it to my specific community? I do like that they give those examples about how it's been done already to give you ideas about how you might apply it in your specific context. In Connecticut, we have the Alzheimer's Disease and Related Dementia Coalition. So their goal here is to create a strategic plan to address Alzheimer's disease and related dementias here in Connecticut. And it's a multidisciplinary, really diverse team of members. So that includes community-based organizations, civic groups, caregivers, physicians, nurses, researchers, public health educators, faith-based organizations, and all of them have the goal of supporting folks with dementia and their caregivers. So they are still actively recruiting and seeking members if you're interested in joining. Their strategic plan for 2023, they have several goals that they've developed. So specifically here for Connecticut, improving coordination statewide across the continuum of care, developing best practices for early diagnosis and treatment. I will say that as a neuropsychologist, often at the point where I'm seeing someone in my office where they're starting to have cognitive difficulties, it's often very far progressed. And while it's always possible to make health behavior changes to promote cognitive health moving forward, really the best changes are preventative instead of reactive. Another goal is to increase public knowledge and awareness of dementia and screening for dementia. Community support for those who have dementia and their care partners. In my office, I see lots of folks, basically caregivers are most often spouses, children, loved ones of folks with cognitive difficulties. And very often they're unaware of resources available to help both with caregiving and to relieve caregiver burden, which often leads to burnout and negative health outcomes for the caregivers themselves. There's the Alzheimer's Association chapter here in Connecticut. So here in Connecticut, approximately 80,000 folks are living with Alzheimer's disease, and that number is only expected to rise. So it'll be an increase of 14% by 2025. Some of the priorities for 2023 are to establish a state dementia services coordinator position, which would be amazing. So kind of a point person to help coordinate care and coordinate the evaluation and development of programs, and also to empower home care staff with dementia training. So it's certainly come up with the patients that I've seen that even folks who are in settings like assisted living facilities or skilled nursing facilities, oftentimes the providers there are not always familiar with the best way to approach changes in mood or behavior, things like hallucinations or, acting out, becoming upset, angry, anxious. Often there are simple behavioral strategies that you can implement to help alleviate those overwhelming feelings, to redirect a person who has dementia and kind of relieve tensions without becoming overwhelmed, either as a patient or as a caregiver. The Alzheimer's Association has a whole section developed to dedicated to developing training resources specifically for folks working in those types of settings. So the goal is to mandate 3 to 4 hours of training for folks who work in settings where they frequently are working with folks with dementia, so that they have those tools at their disposal. And also there are still advocacy opportunities if this is something that you would like to engage in. All right, so we've talked about a lot. Just to summarize, we've talked about social determinants of health, define them, talked about how the environment of poverty can shape an individual's experience and contribute to health inequities. We looked at research highlighting how neighborhoods do matter significantly for health at the national level and local level here in Connecticut. And we talked a bit about resources and initiatives at the national level and more locally in the state of Connecticut that are geared towards addressing health inequities and accounting for social determinants of health with the goal of reducing health inequities. So that's a lot of information and it can be overwhelming. But within that context, I encourage you to think about what you might tell your patients when they're feeling overwhelmed. So one, focus on progress, not perfection. The number of obstacles and barriers are numerous, and that in and of itself can be overwhelming. But that also means that there are numerous points of entry for intervention. And just as things can snowball in a negative direction, they can also snowball in a positive direction. So making a little bit of change can be a catalyst for even more positive change. So in all, I hope to have impressed upon you that addressing social determinants of health is an integral part of promoting health equity, and that there are many ways in which we can exercise our power and privilege to promote change in our own communities. So I'd just like to end on this statement by the World Health Organization, which I think does a good job of encapsulating a lot of what we've talked about today. So health inequities arise from the societal conditions in which people are born, grow, live, work, and age. They're referred to as the social determinants of health. These include early years experiences, education, economic status, employment, work, housing, and environments, and effective systems of preventing and treating ill health. We're convinced that action on these determinants, both for vulnerable groups and the entire population, is essential to create inclusive, equitable, economically productive, and healthy societies. So positioning human health and well-being is one of the key features of what constitutes a successful, inclusive, and fair society in the 21st century is consistent with our commitment to human rights at national and international levels. Stuff to aspire to. So that's all I have for you. Got through that fairly quickly. So we have some time for questions. And thank you all for your attention.
Thank you so much. That was lots of important information that you shared with us.
It was a lot.
And very important, and how to include them as we see patients. So any questions?
I do wonder for folks as you're kind of mulling things over, how do you see this play out with your patient population? What kinds of barriers and obstacles have you faced as they relate to addressing social determinants of health with your patients?
Well, I can make a comment, maybe get things rolling, because I noticed that you had talked about screening and the importance of screening for dementias, which is what those of us who are neuropsychologists are heavily involved in. But in recent years, I've learned more about how that that effort is also extending more preventatively earlier. And that brings up things like community-based screening for hypertension or diabetes. And so not only screening sort of for dementias and trying to catch them earlier, but also moving that up more toward proactive steps earlier. So that's what I find myself thinking about a lot of times when I see a person and they have an early dementia, thinking, well, we can try to do some things to help now, but how can we kind of move that earlier? That was my reaction.
Yeah, I totally agree with you. I feel like often when we're seeing folks in our office, there's a limitation to how much we can alter the trajectory. Whereas if we had seen them decades earlier, or if they had had more preventative care decades earlier, that could have had such a major impact over time.
You know, I'm totally proud to be a neuropsychologist. And mostly I think of it from a clinical point of view, but you've just blown the doors of my brain out on what really social psychology is not a new concept to me. But you've really broadened my concept of social neuropsychology. And your data is I have an intuitive feel for it generally, but it's profound, huge data. And I really am grateful for you sharing it.
Yeah, thank you. Thank you for saying that. It's a little bit scary looking at some of that data, knowing how, I mean, people are often bound geographically, and especially for folks who have fewer resources, if they're living in a place that's under-resourced, it's often not because they want to, but because they just don't have the option of, living in a safer environment, or environment that has better access to healthcare, better job opportunities, education. And you just see how that plays out over the life course. It's very significant. So I struggle sometimes with thinking about this research, because we're seeing people individually, or at least I do as a neuropsychologist. And when you see someone who is having cognitive difficulties, and also they don't have access to resources, it's such a major barrier. It can be really a rate limiting factor in terms of promoting their own health and safety. So it's kind of like what can we do to help our patients, but also want to acknowledge that, it's hard to tell folks to pick themselves up by their bootstraps. It's nearly impossible. So really the changes need to be at a systemic level. So just thinking about both things at the same time. What can we do at a systems level to promote health equity, and how can we support patients who are they're living in their circumstances, and that might not change for them anytime soon.
And the profound truth of it is, this is a concrete manifestation of the abuse of privilege that was institutionally exercised in, as we know, real estate, mortgage,
oh my goodness,
the whole
yes.
thing.
Redlining, housing policies,
yes.
subprime lending, all of the above. Absolutely. And it's all of this is grounded in time and place, and we're living with the historical consequences of those discriminatory policies.
Dr. Ruiz, your data here is the most recent updated version of data I've seen for a few years now. The concept that zip code and health outcomes are related isn't brand new, but your data is really relevant and helpful. So thank you for that. I think over the course of the last 10 years, the good news in this is that a lot of providers in the community, in recognizing this connection, have begun to do some things to try to intervene earlier, or to try to educate clients earlier. I will say that, having come most recently from an inner city behavioral health organization, the Village for Families in Hartford, social determinants of health and the effects of zip code on both mental health and physical health isn't a brand new concept there, but it led to some changes in the kinds of questions asked during initial assessments, and in the kind of interventions offered to and recommended for clients who came to services over the course of the last 5 to 10 years. I think the value of the presentation you made tonight is it's going to enable us to spread this message even further and make sure that nobody misses this. It's true for people in private practice, and it's true for people in the blue parts of your graphs who supposedly are not at risk. But even within the blue parts of your graphs, there are a lot of red areas.
Yeah.
So I think the more that we can do to try to get this message out and make sure that people in private practice and people in agencies are not overlooking this, I think your data and your presentation will be extremely helpful. So thank you. This was excellent.
Thank you. Thank you for saying that. And I agree. I'm glad that you're seeing in your practice that this information is being disseminated, that folks are recognizing the need to take into account social determinants of health, and also how that's kind of grounded geographically and spatially, and that it's actually leading to changes in practice.
Yeah, Linda, I'd like to point out something about another research topic of yours, and maybe try to draw a parallel with this one. If I understand it correctly, I took a look at one of your publications on academic achievement. And what was one of the things that was interesting to me is that you had shown how school climate, the climate within the school and the student safety, moderated academic achievement sort of, not regardless of it, given what's happening outside of the school, that the presence of a positive and safe climate in the school mediates those academic outcomes, and can help promote resiliency. So it made me think about, with the dementia situation, what are our protective factors in the community, or what are those sort of hubs of resiliency that can help with this? And it made me think of our colleagues in community health centers and the tools that you highlighted, such as the Area Deprivation Index from the Neighborhood Atlas, to simply overlay the Neighborhood Disadvantage Index and proximity to community health centers, and then look at dementia outcomes or something like that. That type of thing may help with sort of advocacy and funding, if it can be demonstrated clearly that that type of access has an impact.
Absolutely. And what I love is that there are so many resources for data that's publicly available. You don't need to pay for it. The Area Deprivation Index and that whole project by the folks at the University of Wisconsin is freely available. And it's already in a format where you can download it, you can upload it to ArcGIS, which is kind of the mapping software, and you can essentially connect it or link it to other outcomes that you're interested in exploring to see how they kind of overlay spatially. But it's very compelling. I think one of the reasons that I'm drawn to all of these maps is that it communicates so much information without words. You know, even just looking at it, it has an impact. And I think that assists with ease of communicating some of these results in a way that's, again, more compelling than just seeing numbers on a graph.
We have a question in the comments. I'm curious if you can say more on the findings regarding those unique cities in Connecticut where the incidence of poverty is high, yet it doesn't seem to be negatively impacting on longevity.
That's a good question, and a question that I don't have a great answer for yet. One, I'm fairly new to Connecticut, so I'm still kind of getting the sense of different communities, but I wonder, yeah, I'm not sure. And I'm curious to know, for folks who are more familiar with some of these areas, what you think might be driving those discrepancies. Let me see if I can pull up that map so we can all take a look at it again. I'll share my screen. Oh man, there it is. So I was noticing some of those discrepancies. Oops, did I not share? There we go. Up here near Torrington, I don't know anything about Torrington. And then out here in Eastern Connecticut, there seems to be a lot of differences. For folks who are familiar with these areas, any ideas, thoughts? So this is looking at neighborhood disadvantage by life expectancy.
I wonder if there's an issue related to statistics here. And I was thinking about it when you did your presentation, because if you also look down at the bottom left-hand corner down into Fairfield County, it looks like Fairfield County, the Gold Coast. Everybody knows that's where the rich people live. And yet I've worked with people down in that part of the state who are horribly poor, who have no resources. And in many cases, those are the people who are the hired help or the servants of the people in the higher socioeconomic classes down there. They don't show up statistically. And yet the reality for them is they can't afford a lot of the benefits that the wealthier people can afford down there. Groceries are incredibly expensive in that part of the state. So even though you live in that area, if you are not in that higher socioeconomic class, you can't afford to live down there. And I don't see the damage shown on these slides. I think the same thing is true north of Torrington, where there is a relatively wealthy population going up into Winstead and farther north into northwestern Connecticut. I wonder if it's just a statistical anomaly that we're seeing on these slides in those kinds of communities.
It very well may be. And also, all of this information is dynamic. So it's changing all the time, which I think underlies or underscores the need to continually update our data and our understanding of the issue. But measurement error, absolutely. This is a lot of really highly aggregated data. So there might be anomalies that are related to statistics and errors of measurement, or not capturing a representative sample of those communities.
I'm wondering if some of it might be related to some of these areas being poorer economically, but having stronger social stability in terms of people that have known each other for a long time, little towns where everybody knows everybody else, where there's support within the area.
Yeah, I'm also wondering.
Income levels may be a lot lower, but quality of life and other areas may be quite good.
We also see some environmental impacts so a city like Bridgeport and some of the cities where there'll tend to be more pollution, but when you're in some of the quieter corners of the state where we don't see as much of an impact as we do in a city like in some of the city areas like Bridgeport and New Haven and Hartford, that might be less contributing. That might be an important contributor. There's more fresher air in the quieter parts of the state, even though there is significant poverty, but it's not as condensed. It's not as dense as well.
And potentially more opportunities to just be out and active. Yeah, all of those are really great hypotheses. I will say that for areas that tend to have fewer resources, often one of the characteristics is high turnover, which becomes really difficult in terms of building those kind of cohesive social networks that can result in having a more supportive environment, living in an area that feels safer. So I think interventions that promote that type of social cohesiveness are also very important.
I do have one question. First off, this was excellent. It's just really fascinating to, I think, see the images. It's something about stats, but a whole different thing when you're actually able to see a lot of this. And the question I kind of have is, how do they define like least disadvantages? Is it mostly socioeconomic status, or is it taking into consideration like access to doctors, hospital settings, or is it just solely socioeconomic? Because out of curiosity.
Yes, excellent question. Let me get back here. Yes, so the ADI index, so they have a whole paper that goes through the methods of how they develop this index, but it does include, for example, things like income, education, employment, and housing quality. I think there are many other indicators, so it does quantify several different indicators, 17 factors that are indicators of material and social conditions. So it's not limited to those things, but I think the idea is essentially just trying to quantify to what extent an area confers basically access to these resources. So relative I guess, relative privilege.
I was just asking because I'm thinking back to my experience. I was working in the state of Georgia for several years, and it was really fascinating for me when I moved there, just because we had two separate regions, one side of the street very wealthy, the other side was not. But regardless, there was a limited, it was basically like a hospital desert. We didn't have many specialists. And so I was just kind of curious to know whether there may be kind of links with just kind of access to specialists within those particular regions or whatnot. That can certainly play a role. And if you do come from a wealthier background, you're more likely to be able to drive an hour to a Mayo Clinic. But if you're not, you may be kind of stuck in that
Yes,
physician.
absolutely. I am not entirely sure whether or not that's accounted for within the ADI index at this point, but my hypothesis would be that generally in areas with more disadvantage, it's more likely that they will have less access to medical resources, affordable food, green space, those types of things.
In this era of political polarization, a lot of scientists in different fields are getting some pretty strong pushback, and I'm wondering and concerned whether you've experienced that at all.
I feel like not yet, but I'm sure it's coming. But, you know, I understand why some folks might think, like, what is the utility of focusing on all of these differences? You know, we're all human after all. But the fact of the matter is there are significant inequities, and it is important to describe those inequities to raise awareness. And that way, with data like this, we can influence policy. I don't think it makes sense to be blind to those inequities.
Well, if push comes to shove, I'm sure I'm speaking for many of us that you should know we have your back.
I appreciate that. Thank you very much.
Thank you so much, Dr. Ruiz. That was excellent. So, Minna, can we go through closing remarks? I think there are a couple of more questions, but it's 8:04. Let's close the meeting, and if people have questions, we can stay a few more minutes.
Yeah, I think just one, someone asked if the slides will be shared.
And we will inform you about that.
Oh,
I'm happy to. I can send them out to you.
okay. Well, thank you for joining us this evening. Our next social justice event will be on December 7th, and our speaker is Dr. Galina Portnoy. I want to end by mentioning that our ability to maintain the social justice speaker series is through fundraising, and we greatly appreciate all donations moving forward. If you're able to support, the donation link and mailing address are in the chat. And if you're registered for CE, I also invite you to complete the CE evaluation link that you should receive in your email to receive your CE certificate, which is now being added to the chat. And thank you for joining us this evening. We look forward to seeing you at the CPA convention on November 3rd.
Thank you all.
Everyone.
Thank you.